Good afternoon, everyone. Welcome to the EASL Studio, your weekly hepatology broadcast news. And today in the studio, we're actually going to aim to discuss some of the hot topics in the endoscopic and non-endoscopic management of patients with acutely bleeding esophageal, gastric, and possibly even ectopic varices if we can cover it. And I'm joined by two real experts in the field. I couldn't think of two better people to join me in the discussion today. So we've got David Patch from the Royal Free Hospital. I'm sure everyone will know him and he needs no introduction. And then we're also joined by Prof. Wim Leilman from Leuven in Belgium. So welcome both.
Hi. Thank you.
Studio. And David, I'm going to start with you because I was a registrar once upon a time when you were a consultant, and you used to teach me and many other registrars about the absolute basics in managing variceal bleeding. And I know there's lots of trainees that will be listening to this studio today and young endoscopists, but also consultants too. And I wondered if you can kind of talk us through kind of how we should be managing acute variceal bleed.
Thanks, Debbie. Yeah, it's a sort of bête noire of mine, I have to say, because I really do think that initial management, if you get it right, it makes such a difference. And I have to say, trials don't usually measure that or incorporate that as a metric, because if the patient has good resuscitation, they don't aspirate, then the bit that Wim's amazing at endoscopy is so much easier. And the patient's outcome, I think, is profoundly affected. So what I think is good management is just classical ABC, really. The airway is really important. And I know at the last Proveno there was discussion about, whether intubation was deleterious for patients. I categorically think that patients who are actively bleeding should be intubated. And if you're to do safe endoscopy, then the patient should be intubated, and particularly if they're actively bleeding. And actually, if they are actively bleeding, if a registrar is seeing a patient and you haven't got an anaesthetist there with you, just get the patient head down so the blood's just coming out of their mouth. It can just land on the floor. But the important thing is not going in the lungs. Once you get everything ready, you can get cannulas in, get the blood cross-matched, get fluid ready to go. You've got your friendly anaesthetist ready to intubate the patient. And again, it should be a trauma intubation with sort of ketamine, and a muscle, ketamine and sucks, really, to just maintain that airway rigidity. And then you can crack on with the endoscopy once you've got that airway protected. And for me, it just totally changes the pathway of the patient. Everyone can relax once the airway is intubated. And it's very rare a patient actually exsanguinates. Very, very rare. But they do die if they aspirate. And one of the tricks actually I have used as a consultant is, if you've got a patient, if you're not getting the right response from the agencies around you, is I just pull the crash bell, because there's a lot of blood on the floor. It always looks really dramatic. And then you get your resus team with you. You'll get an anaesthetist. You'll get an ODA or whatever. You'll often get a part team. So for registrars listening in, that is a good tactic if you think you're losing control of the situation. Then get some fluid in, and then the question is what agent to use in terms of the management of variceal bleeding. And I've got a little bit of a bee in my bonnet about terlipressin at the moment. I am seeing patients coming in with lactates of 8 or 9, and they're powerfully vasoconstricted, and they're underfilled. And actually, the recent data, I think, I'm struggling to support the use of terlipressin routinely, because somatostatin and octreotide are probably as good, and terlipressin categorically has more side effects than those other two agents. So I am wondering why we're routinely sanctioning the use of an agent which is no better than two others and yet has significant side effects. So Wim, I'm going to throw you back to, I'm being a bit controversial here, but push back on that if you disagree.
Wim, what do you think?
Or in terms of vasoactive substances, you mean? Well,
yeah,
I think first of all, it depends on what you can get your hands on. I mean, there are some people that cannot get terlipressin or cannot get somatostatin, Often this has to do with national policy or even local pharmacy policy. So that's the first thing. I think whatever you can get is already a good start. If you have the liberty to choose, I have the same constraints as you do. So I would, if I have a patient that is after resuscitation, because fluid resuscitation is the first thing to do, if the patient stabilizes somewhat, is not in deep hypovolemic shock, certainly if it's someone with a cardiovascular history, then I would go for somatostatin, and then use the bolus and then the maintenance drip, and then consider to double the dose if you have active bleeding at the moment of endoscopy. So that's, I think, a proven concept.
The other thing, I'm going to interrupt you as
Yeah.
well, because don't forget, we're getting a lot more MASL patients coming in for bleeding, aren't we? And they've got cardiovascular
Absolutely.
issues, they're diabetic, etc.
Yeah.
Absolutely. And then terlipressin, I would reserve for the patient that is, after resuscitation, is still in fact hypovolemic and needs vasopressor support. Then I think it's a good choice. Also, if the patient already has some renal insufficiency with the concept of renal dysfunction in the context of cirrhosis, then I would opt for vasopressin. But I think it's important to emphasize that if you use terlipressin, that you need to use a higher dose than for hepatorenal syndrome. So that's a common mistake I see often, that people give like 4 times half a milligram. So you need to go to 1 milligram, and then even you need to consider weight, because the doses of terlipressin are vast more higher than in fact those for hepatorenal syndrome. So I really make it depend on the context of the patient, and I have the luxury to have access to both. So that's my take on things. So I'm tackling you partially back. I don't know.
That's all
And
good.
you know what? I'm going to just stop you a second, David. What about correcting clotting? So if you've got a sick, decompensated cirrhotic who's got platelets of 50, an INR of 2, what do we need to correct the clotting, or do we just need to get on with the endoscopy?
I don't think we need to correct clotting.
Okay.
I have to say, though, what's interesting is that I find that once I've got the anaesthetist involved, I actually lose control of that resuscitation process. So they often very much take over control, and they worry about platelets and clotting, and next minute you find platelets are going in and FFP, which is probably not just not required, but may actually be the wrong thing to do, because if you look at TEGs after FFP, they're actually worse, and there's some data that portal pressure may actually go up after FFP. So keeping that control of the resuscitation process can be quite hard, and it's the same as hemoglobin target. So I think hepatologists are very comfortable with targets of sort of between 70 and 80 of hemoglobin. But as soon as we've lost control of that, you find bloods going in almost like a trauma resus, as opposed to a cirrhotic bleeding resus. It slightly changes.
You touch on an important point there, David. I mean, the packet cells or the blood cell transfusion. I mean, it's often in that situation where a lot of blood is on the floor, as you already mentioned, that people start to use liberal transfusions. So I think we really need to emphasize to the audience that they should apply a restrictive transfusion, because in fact you're counting on the relative anemia and the splanchnic vasoconstriction it causes, which will decrease the portal pressure. So I mean, it clearly has been shown that liberal transfusion increases the failure to control bleeding and increases mortality. So this is really an important message, as is in fact that we don't need to correct coagulation. So I mean, there's a rebalanced hemostatic system in cirrhosis. So this is really, really, really important, because it happens too much and too often that this is the case. So.
And then antibiotics. In the era of antibiotics, I'm struggling with now, because actually the data is really quite good for antibiotics, prophylaxis in variceal bleeding, and yet in the era of multi-resistant bugs, you kind of feel that we need to modify that and perhaps preserve antibiotic prophylaxis for, say, the Pews Cs, because the Pews A's and B's infection is much less of a problem, and they're more likely to do better. Pews B shouldn't die of a variceal bleed. They absolutely shouldn't. And so at the trouble is, if you put a guideline, say you actually have to then, well, think if they're Pews B, you don't give antibiotics. That then makes a guideline really complicated, and then the next minute people don't follow it. So it's a tricky one. But at the moment, I would still say we should do it.
Okay. Okay.
Yeah. The other thing, of course, of interesting is that someone comes in as a Pews B. A day later, their bilirubin's gone up, their albumin's dropped, and they're actually a Pews C, aren't they? Because that's what happens with these patients. Yep. And again, that's one of those dynamics that's never really picked up in trials, because, you know, it's when they're randomized that were they a B at that time, or were they a C, or did they transition? But they often do, don't they? They start off as a B, and then 2 or 3 days later, their bilirubin's 70 or 80, and their albumin's dropped, etc., etc. But so yeah, so restricted transfusion, airway protection, 100%. Antibiotics are on board. The patient's nice and stable. I'm handing it over to Wim because he's the endoscopy king.
So Wim, tell us about the endoscopy.
Well, I think the provocative title of the studio was whether you still needed endoscopy in a time where TIPS comes up to speed. I think we should emphasize that there is still a must do of endoscopy. So, I mean, this is obviously a necessity, and it's not because, and maybe probably we'll talk about preemptive tips and rescue tips later on. I mean, it does not dismiss us from the task of achieving or pursuing hemostasis. I mean, this is the case for every upper GI bleeding, because, by the way, if a cirrhotic comes with hematemesis or tardy stools, it does not mean per definition that it's a variceal hemorrhage. I mean, the chance is high, but you can have an ulcer, peptic ulcer bleeding as well. So, I mean, the approach in that aspect will not change, because if you use somatostatin, you will give an antacid as well. In the event that you give terlipressin, well, then you need to add a PPI if you consider that option as well. But so I think there are two main aims of endoscopy. So the first one is to make a diagnosis of variceal hemorrhage versus non-variceal bleeding. That's one. And the second one is, of course, hemostasis. But in the context of variceal hemorrhage, the hemostasis is of course an important goal, but it's not the only goal, because, okay, you want to control bleeding, but you want to prevent early rebleeding, which is always a risk with these patients, and we will define, I presume, later on, the high-risk patients being the child B patients with active bleeding at the moment of endoscopy, and the child C patients. So these are the high-risk patients for rebleeding. And on the other hand, there's also something like bleeding-related mortality later on. So you save the patient in a heroic endoscopy in the middle of the night, satisfied with yourself that you finally achieved hemostasis. And then, of course, you follow the patient later on, and he dies from acute on chronic liver failure or bacterial infection. So it's very important that we do the endoscopy as soon as possible, but of course, while maintaining a window of true opportunity. I mean, often it happens also in my unit that the endoscopist or the young endoscopist is already at the bedside while the anesthesiologist is still resuscitating the patient, or is still looking for intubation. I think you need to resuscitate and stabilize the patient first, and then come with the endoscopy. So don't come too early, but on the other hand, don't come too late. There is some evidence. It's a difficult thing to study, I think, but you need to do the endoscopy within 12 hours. I mean, there have been some data, okay, mainly retrospective, where they did the endoscopy after 12 hours, and then you can see that the mortality goes up with a factor 4. If there's hematemesis involved and you do the endoscopy in a delayed manner, so also beyond 12 hours, then the mortality goes up with a factor 8. So there is something to say for that endoscopy that they phone you for in the middle of the night. Yes, we need to do it. Even if you consider the preemptive tips pathway, we are obliged to take the integrated algorithm, as David already started. The endoscopy is one of them, and then you need to look on. So that's, I think, the take on the endoscopy, at least.
Okay, that's great. And what should be kind of the skill set of an endoscopist doing one of these things? Because you know, there'll be a lot of trainees on bleeding on call rotors that will be faced with these kinds of cases. And what's expected of them, and when should actually they actually pull back a little bit and ask for more help?
Well, I think, I mean, endoscopic hemostasis is one of the basic skills and one of the basic necessities of every every GI person. So, I mean, I'm trained as a gastroenterologist, but of course I went on to hepatology and biliopancreatics. But I think this is a part of the basic skill set of every GI physician. Whether it's an ulcer, whether it's varices. I admit, I mean, the esophageal varices are somewhat easier proportional or relatively to treat than the fundus varices, the stomach varices. I mean, but the chance that you have a stomach varice is 1 in 5, where the esophageal varices will be 4 out of 5. So I think it's important in the trajectory of training that people are dealt with variceal bleeding, had the opportunity to put band ligation, had a kind of mentoring, at least to have done several bandings. So this is an important skill set. The gastric varices is more of a challenge and also gives a lot of stress to people, I noticed, in the sense that this is less controllable. I mean, they bleed less, but if they bleed more intense, and they're also more difficult to control because there's blood coming everywhere. You can't see it. So that glue injection is somewhat more of a tricky thing. But then sometimes, I mean, you just have to jump into the water and swim and try to get with every possible means. If you're all on your own, well, then you need just to save the patient by offering hemostasis. It's obviously more easy if you have a team behind you or people that you can call who have a more advanced skill set so that you can do it together. But at least, I mean, the banding is a basic skill set. The glue is one you preferably would have, but it's not so easy to obtain and requires some technical aspects that you would need to consider. So I think that's my take on at least the endoscopic approach.
And one thing I would like to add, let's say you, for the registrars who are this, let's say you haven't got control and you've still got bleeding. The one thing, you reach for a Sengstaken tube. There's one trick I would really recommend is you use the endoscope to drive the Sengstaken tube down. And that way you then retroflex, you can see the balloon in the stomach, you can inflate the balloon. And so you're effectively inserting it, the Sengstaken under direct vision. So there's really no risk of perforating the esophagus, which is is a death knell for these patients. So it is it's a really useful technique for getting a Sengstaken down safely. And then the other thing is to make sure if you're transporting that patient to another place, let's say for a TIPS, that Sengstaken tube has got to be on some traction. If it's not on traction, it's not working. It's not going to do anything. It's actually got to be on traction. Now, I have arguments with one of my ITU consultant colleagues here, but I just think 500 ml bag of saline just hanging off the end of the bed will get them transported safely.
Yeah.
Wayne, what about the Danish stent then in that situation? So I guess you've got to have scoped the patient first, haven't you? Because the Danish stent doesn't work for gastric varices, does it?
That's the problem. I think if you have a problem with an unstable patient in which you cannot obtain hemostasis, it's most commonly the guy or the woman with the gastric variceal bleeding. So that's the issue. I mean, I hear you talking about the Sengstaken, but there's a problem with Sengstaken because I don't know in the UK, but at least in Europe, I know from different colleagues that they're not so easy to find. And if you have one, it's not used so frequently that already they have gone beyond their expiry date. So that's an issue. But of course, it's always, I think it's a good, it's worthwhile mentioning that it's a good thing, I think, to have one in a backup. And what you told with the endoscopy assistance in delivery of that Sengstaken is very important. The Ella Danish stent, I haven't used it that many because usually you can obtain hemostasis for esophageal varices. It's very rare that you would not have control with the esophageal varices. But this is an option.
That's a good endoscopist speaking. So
Yeah.
I use it. Now the trouble with me is I use it. I have to get the video out on YouTube to look how to place it, and then I place it and I go down and look and go, oh God, it's in the wrong place, and I end up I end up placing two The other thing slightly with a Danish stent is they do move.
Absolutely.
Yeah, I was going to say that they displace quite quickly and end up in the stomach, and then you try to retrieve it, and then you start the bleeding again. So there's probably a time and a place for using them. Yeah,
I think the message is that it's good to have a kind of anticipation for a rescue scenario, whether it would be Zengstaken or Eladenis. Okay, know about the difference between having control over the gastric varices and esophageal varices with both, but I think it's worthwhile to consider it in your unit just in case of such a situation, which hopefully will not occur too much. But if it occurs, you're at least prepared, because that's also something which we will need to emphasize. You've mentioned all the steps that we need to take with the ABCs, endoscopy. I think it's very important that every hospital, every unit has a kind of algorithm that fits with your local facilities, so that everyone knows what to do in the event of having someone with suspicion of variceal hemorrhage, because there's nothing so stupid as having people around you that really don't know what to do or what needs to be done. And so in those situations, it's very important to have algorithms that you can just deploy and of which everyone is aware of. So I think that's a very important point as well.
Now, hopefully, we're all good enough endoscopists that we go down and we do some good banding and we control the bleeding. But unfortunately, life isn't always like that. And sometimes it doesn't work, or bands ping off, actually. I think it is not unusual. So when would we need to start thinking about calling in help from interventional radiology or thinking about tips?
So there's sort of three different scenarios, I guess. So there's the salvage tips in that patient who's, let's say, been endoscope rebled, has got a Zengstaken tube. So that's a patient who's effectively not been stable, or needs some rescue therapy. Then there's the preemptive tips, which is the patient with high risk for rebleeding and mortality. So Pews B with active bleeding or Charles Pews C. And those really are patients who are stable. They've stopped bleeding, but they've been identified as high risk. And the argument is they should go down a preemptive tips route. And then there's secondary prevention of bleeding. Now, I think there's only really one good trial of secondary prevention of bleeding with tips, which was by Saarbrück, and I think it's a really good trial. And actually, tips in secondary prevention just caused more encephalopathy and didn't change survival. So I think one has to be quite cautious about tips in secondary prevention. There is a group of patients who do, I totally get it. If those have been emotionally scarred by a variceal bleed, they just want that. They never want to have that experience again. Or if they're working in sort of resource limited environments, or they live a long way away from medical help, then yes, I totally get you want to just take the portal hypertension out of the equation. But I think otherwise, secondary prevention, when it should really be in a trial if you're using tips in that scenario. So the salvage tips, those are the patients who are transported by ambulance overnight, intubated likely, and then we just crack on with those. There's no point in waiting around, but they all need a CT. I have to say, if you're not well enough to go for a CT, you're not well enough to go down for a TIPS procedure. So
okay, good point. Yep.
Because every now and again we pick up the portal vein's gone, or we actually had a patient transferred by helicopter to the Royal Free, which was funny in its own right, but actually transferred many miles, but they hadn't had a CT, and this patient actually had sort of arterial fistulae as the cause of their bleed. So you need to know the anatomy of that splanchnic circulation. So CT definitely, and then over to the radiologist.
Okay. Now the other thing that you can do, Wim, is EUS, and you're a bit of an EUS expert, aren't you? So what would be the role there?
That's a challenging question. I think you're asking the question maybe a little bit too soon, because I think we still need to debate on the tips, if I may come back.
Okay, no, let's go back to that then.
Because I mean, in the past we only had one hammer that really was for every nail. So I mean, it was medical and therapy, endoscopy, and that was it. And then the rescue tips was the solution when everything failed. So, and then they said the rescue tips rate is the funeral rate. So I think it still is. So that's what you want to avoid. So that's, I think the preemptive tips is a very important concept. I think which has proven really its value. I mean, you have an absolute risk reduction in mortality of over 30%. So this is really something, I think if you finish the endoscopy, that's also something worth mentioning. Some people are happy with the fact that they went through the cycle with medical therapy, endoscopy, achieved hemostasis, and then it's done. No, I think every time you need to ask yourself, is this a patient which in the next step, because achieving successful hemostasis does not prohibit you to go on for a preemptive tips. On the contrary, I mean, it's just the next step that you need to consider. So I think you need to ask yourself, does this patient need a tips, or should I consider it at least? And then you need to reach out to a center that is your referral center or the center with expertise. So I think that's always something which should be considered. So David mentioned the high-risk patients. So that's an important thing. I just would like to come back to the secondary prophylaxis. I mean, our approach would be to give the patient, if he's not an early or a preemptive tips candidate, is to go on with beta blocker and banding until the varices are eradicated, or glue embolization until the varix is obliterated. But you talk about tips in secondary prophylaxis. I rather see tips there as if the guy rebleeds during the medical endoscopical secondary prophylaxis, then the next step would be tips, I think in secondary prophylaxis. So
yeah,
I just wanted to put that nuance out there, because you're right. I mean, it would not be the first go, but at least there's also a place for that particular intervention in that setting. And then coming back to the EUS, it's EUS is something which is like exploding. I mean, we've come a whole way with the endohepatology thing, so we can do a lot of good things for liver patients. And of course, I was talking about one hammer for every nail. Now you need to consider several hammers and pick your nail. So there is a place for EUS in the sense that I would not apply that for esophageal varices. I think banding there is really the number one endoscopical intervention. It's really about the gastric varices. So the GAV2s, the ones that extend into the fundic region, or the isolated gastric varices in the fundic region, or the IGV2, so the ectopic varices. That's a different class, but you could all consider them together. I think there you can really do something valuable with EUS. But again, sometimes people say, well, if you have a new hammer, everything looks like a nail. So just to stay in that paradigm, I think you always need to consider what your options are. I mean, there are several routes that you can take. So tips is one, then you would of course give portal decompression, and then of course solve the problem of the gastric varices potentially. Sometimes you can't consider a tips approach if there's a portal vein thrombosis that you cannot overcome, or it's left-sided portal hypertension. And then of course there's the EUS approach, then you can consider BRTO approach. So that's also an interventional radiological intervention, where in fact the radiologist comes in a transvenous way and comes back up to the varices via in fact a portosystemic collateral. But of course you need to have the anatomy. So I think CT there is also again important to make or choose your route. And then of course you have the EUS approach, which is also a valuable thing. So you need to balance all of those options, and you can already hear what I'm saying: tips, BRTO, EUS. So in the acute setting of a bleeding, it's very difficult logistically to move all your gear for EUS to the emergency room. So in our system, this is not the primary goal. We would still go for the conventional untargeted glue injection. But in the event that you have a stable patient and you need to go back, or you need to do additional embolization, then in fact EUS is a very nice and powerful tool, because you can really pinpoint the varix. Because don't forget, esophageal varices are fed by one perforating vein from paragastric veins or collaterals, while in fact the gastric varices is usually a more complex vascular structure with a lot of feeding, so afferents and efferents, and it's not always easy to do a good traditional untargeted endoscopic approach where you just think, well, I'll inject there because that seems like a good spot. That's what it is. It seems like a good spot. I mean, there have been studies where people looked at the true injection of glue into the varix, and apparently 60% was next to the varix rather than in it. So just to give an idea, and with EUS, you really have a real-time guidance of your ultrasound. You can look for the afferents, you can look for the efferents. So sometimes even you can see the gastrorenal feeder, you can close it. And so it's an approach with coil and glue. So that's also the difference with the traditional endoscopic approach where you just inject glue. So in terms of
so Wim, I'm going to interrupt you. So
yeah.
this is a sort of Real Madrid versus Atletico Madrid question. Are you thrombin or glue?
Thrombin, well, I'm aware of some data on thrombin. I think Dheeraj Tripathi did some papers on it. It's not something that we have available, at least in Belgium. And I'm aware of the thrombin. I mean, it's a very good product, apparently. It gives you less systemic embolization. But
Well,
we don't
I think it probably still does. It's just that you don't add Lipadol to it, so you don't know where it goes.
Well,
so
according to the small amount of publications, so there's only one RCT to my knowledge where it had some better effects than the counterpart. But so thrombin is not an issue, but it's very important for EUS to combine coil with glue because we use the coils from the interventional radiologists. We borrow them in the sense that you first put a coil and then in fact inject the glue, you drip it on that coil, which has synthetic strands, and in fact captures the glue in situ, which of course gives you better results. But in terms of acute hemostasis, EUS is not better than traditional, so that's an important point. But in terms of early rebleeding, obliteration, well, EUS coil plus glue is far much better than, in fact, the traditional approach. And in terms of embolization, which everyone fears, EUS coil plus glue has a tendency to outperform the traditional approach, where of course you don't know where you inject, and there you have a kind of 4 to 5% risk of systemic emboli, which can be quite brutal. So that's always a consideration.
I think certainly the radiologists, when they're embolizing, so the quantity of Lipadol they mix will affect the hardening. So with glue, it's either pure glue or actually a sort of 1-to-1. So if you've got a high flow system, you need the glue to actually set in situ, and if it's a low flow system, you can have it a bit more dilute, so it percolates further into the smaller vessels. So I think for gastric varices, you really need to be using I'd be saying a sort of 1-to-1 mix of Lipadol and glue, because you don't want that, as Wim has said, you don't want that glue traveling. I'm going to put a slight Brexit bent to this, I'm afraid, because so the preemptive tips thing is in the UK we're not believers yet. There's the Scottish study which suggested there wasn't a benefit, and I think the numbers, we do need bigger numbers in trials to answer this question, because it's a really important question, isn't it? Because it has profound impact on how we set up services. You're going to have a lot of patients traveling around the country, etc., etc. So we've got a REACT AVB study going on at the UK, which is going to hopefully randomize 200 into each arm, because actually at the BSG did a big audit of bleeding recently in the UK, and TIPS use in variceal bleeding was just 2%. Now that's up from 0.8%, but it was just 2%. And yet mortality, in hospital mortality was 13%. So that's probably quite respectable. But the delivery of that preemptive tip service in the UK would be really challenging, I have to say.
Well, I think it's going to be challenging for a lot of centres across the world, because we've got viewers that listen to the studio from all over the world, and not everybody's as fortunate to have access to some of these things. So that's why I think getting the basics right is such an important conversation. I don't know if I can, because I'm aware we're sort of running out of time, and Wim's putting his hand up. Go on, put your hand up, Wim.
Can I put a comment to that? I mean, we on the continent, because we have to start thinking like that, people from the island and the continent. We on the continent are very much in favor of the preemptive tips.
Oh, I know.
Yeah, and I think the data are really there. I think we need to acknowledge that. I mean, there
No,
have been
sorry.
individual patient data meta-analysis showed really a confirmation of the initial trial, and also there has been a Chinese trial which has taken the same
So
criteria.
the initial trial was just 30 in each arm. That's it.
Yeah, but still, I mean,
And
if
it
you
was a
look,
combined endpoint. So
yeah,
the only endpoint we're interested in is survival. It was a combined endpoint. I have to say the concept makes sense. Okay, the concept makes sense, but I'd like to just see it firmed up a bit more.
Well, we're going to have a nice randomized controlled trial, David, aren't we? That's going to show the answer. So.
I can follow your reasoning, and I mean, if you look at the numbers needed to treat, you only need 4 patients with variceal hemorrhage and high-risk varices bleeding to save 1. I mean, and if you look at myocardial infarction, you need 30, and still everyone is prepared to take on patients with myocardial infarction, and we would not do it. But you're right. I mean, there is a problem with rolling out the platform of tips. So, I mean, there has been a French, there has been a Spanish, and I think also a recent American paper where they looked at, in the end, 7 to 10% of the patients that were eligible for a preemptive tips only got their tips, meaning that, in fact, over 90% did not get what they needed to get, in fact, a good and successful treatment. So there's certainly work to do to get that organized, and it should be. I mean, for stroke, we have systems in place. For myocardial infarction, we have systems in place. So why not for preemptive tips?
Okay.
No, it's not an excuse.
Now I'm going to stop you there, just because I think we've only got about 5 minutes left, and actually we haven't really talked a lot about. We haven't talked about rectal varices or duodenal varices, or actually peristomal or stomal varices, which I'm increasingly being called about in the middle of the night, and they're really difficult. I don't know if we could just have a moment just to have a little think about those kind of special situations, and if you've got anything you want to sort of add to managing those.
I'll say CT is critical.
Yeah. Okay.
Because CT will tell you, have you got feeding vessels? Have you got? So the trouble is often that the typical scenario is the PSC patient, isn't it? They got portal hypertension. They've had a colectomy for their inflammatory bowel disease, and the approaches for those. So if I deal, Wim can talk about EUS because that also can work for these patients. But we'll try both transsplenic, transhepatic approaches, and you just effectively identify the vessels that are feeding that varix, and you can embolize those. And our policy is to embolize first, and not necessarily put a tips in, because actually these patients bleed at low pressures. So if you actually measure the pressures low down, they bleed at less than 12. So the sort of magical 12 threshold isn't relevant for these ectopic varices. They bleed at much lower pressures. So our approach is embolize first. It's not uncommon those patients will rebleed at some point because they develop more vessels, and then under those circumstances, depending on the scenario, we would consider a technique to lower portal pressure and embolize, and that's where the tips is quite useful. Often put a very narrow tips in, but we then use that as a conduit to go down and provide further embolization if required. And that embolization can be with coils, it can be with glue, it can be with foam, it's whatever. And that works for rectal varices or stomal varices. But if they've got a profoundly thrombosed splanchnic circulation, then it's over to Wim, because sometimes there's just no way you can get a catheter down there.
And just before we come to Wim, is there ever a role where we should be trying to glue rectal varices endoscopically in the middle of the night, or should we just be going straight for a CT and doing a more targeted approach?
They're really difficult. I've seen some really bad glue ulcers in the rectum, and they are so difficult. We've put Sengstakens up there for no reason other than I think it just stops the blood going on the floor. They're really tricky. I think definitely less is more if you haven't got EUS guidance. I would refer to I'd send them across the channel over to Wim.
Okay, thanks.
So Wim, over to you. What's your thoughts on
Yeah, these are the more advanced, complex cases. So I think you all feel that we're struggling on how to manage them. There's not a it's not in the same fashion as you have the esophageal varices or upper GI varices, where you have an algorithm that is really rolled out. So these are the exceptional situations. I think the first advice is if you have such a case, please reach out to a liver center that has tips, interventional radiology, and advanced endoscopy. So I think this is the first point of advice. The second is for ectopic varices in the upper GI, as David already said, it really matters what is the vascular anatomy. I mean, you often the ectopic varices are often excluded vascular territories, which in fact are hard to reach for the interventional radiologists, although they have their ways in coming via BRTO approaches if there are portosystemic collaterals, but then you need to have them first via, or you need to detect them via CT. In the event that it's not, I think there's still also a role for the surgeon. I mean, then going back to the traditional option. So a patient, if stabilized, because this is not something you can do when a patient is actively bleeding, but in a second phase, it's always worthwhile to have a kind of a conference with the surgeon that has experience in those kind of vascular shunts. I mean, they're rare, but they still exist. And then you have the interventional radiologist and the endoscopist, and then you need to make a plan where, in fact, you say, okay, we'll take the first go, you are the second, you are the third, and then it's in fact deciding in the best interest of the patient. So it's not because you can do something technically that it's always the right pathway. So you need to decide multidisciplinary before you take a go. In terms of acute hemostasis, I think again for upper GI, glue for ectopic varices is a good option. If you can do it via EUS, it's even better. I have several cases like that with now, and they're doing really well. So I was used to doing untargeted glue injection, the traditional approach, but now with the coil and glue, you can really pinpoint, you can really selectively embolize and also in a durable way embolize that varix. For the rectal varices, that's a tricky one. Usually it stops by itself, but in the event that you would have someone who is bleeding, and you don't know how to proceed and you will lose the patient, then I would put a band ligature on it endoscopically, just to have hemostasis, and then you really need to come up with a plan. And then again, it's like David said, it's either interventional radiology or if you do an endoscopic approach, I would do it indeed via ultra EUS guided way, because it's even more difficult in the rectum to have a kind of targeted injection, and you really have to have an oversight on the vascular anatomy before you really engage in something. But usually it will stop by itself if you start somatostatin or terlipressin. But in the event that you're really stuck and the patient is getting hypovolemic, then I would put a band ligature but it's exceptional. I mean, I've only seen it like a couple of times where it was necessary to buy time to make a better plan. But these things really need liver units with experience and having multidisciplinarity. So that would be my take on that.
So I'm going to add to that, Wim, because actually, literally, what you're saying is real life. So we've got a patient here who we are now considering splenic embolization followed by surgical splenectomy for we still need our surgeons in portal hypertension. So patients who have particularly extensive splenic vein thrombosis, or indeed just isolated splenic vein thrombosis, where there isn't a BRTO approach, there's no clear target for a transsplenic embolization. Actually, we need our surgeons, and they need loving and kept on board.
Absolutely. I mean, there's different. So you have the shunt surgery, so making a shunt. The other way is, of course, the modified Sugiura, where you have a devascularization of the stomach and splenectomy. It's rare, but I mean, I can remember 2 cases last year where we really got into trouble, even endoscopically. So, and where the surgeon saved the day and saved the life of the patient. So, yeah, you need to look at this with different glasses or with different hammers, and then you take the right hammer for the right nail.
So actually in the UK, what we're trying to establish is a clear network of places which include not only the tip side of things, that sort of, but actually where they're surgeons as well. Because I think
Yeah.
You're absolutely right. You need all of those skills.
Yeah. Now, I think we might need to draw the studio to a close, I'm afraid. We've had such an amazing discussion, but our time is up. But I think we have established that endoscopy is not outdated. It's very much needed, along with our surgical colleagues, but we definitely need complementary approaches, don't we, in terms of using tips and EUS-guided therapies as well. So I think that's a really nice conclusion that ticks everybody's boxes. So look, I'd like to thank you both, David and Wim, for fantastic discussion and sharing your knowledge. And just to remind everyone to become an EASL member if you're not. And to join us next week, we've got an interprofessional session implementing the new EASL MASLD guidelines into clinical practice. So please do join us then. So thank you once again to our panel, and I wish you all a good evening. Goodbye.
Bye.